Hello and welcome to the next instalment in your neuroanatomy venture. I am Tanya Chamberlain from the Division of Anatomy here at the University of Leeds, and in this video we will be looking at the blood supply to the brain and the production and the circulation of cerebrospinal fluid. But why are we learning about this? Well, the CNS has an incredibly high demand for glucose and oxygen. And how does this reach the brain? Well, through the blood supply, of course. In fact, of all the blood oxygen we use throughout our body, the brain accounts for just 2% of our body weight, but uses approximately 20% of our blood oxygen. Additionally, one of the most common causes of neurological defects is due to a vascular issue. And we also know that there are many anastomoses between the vessels of the head and neck. That means that there are many routes of infection to the CNS by the blood supply. So let's go and have a look at the learning objectives for this video. After this video and any further self-directed study, you should be able to outline the blood supply of the brain and describe its key branches. Describe the distribution of the main arteries and the pathological consequences of a blockage of these vessels. You should be able to describe the arrangement of the meninges in the cranial cavity and in the spinal cord. You should be able to outline the venous drainage of the brain and describe the ventricles of the brain, including the choroid plexus, and outline the CSF circulation. You should also be able to describe the functions of the CSF and outline the consequences of an obstruction within the flow of the CSF. But for now, we will focus on the blood vessels. To ensure that we're all singing the same lyrics, we need to recap some of the important arteries of the neck. This is the common carotid artery. As we are looking at the right side of the patient's neck, this common carotid artery is coming from the brachiocephalic trunk. If we were looking at the left side of the neck, we would see that this artery is branching directly from the arch of the aorta. Approximately level with the thyroid cartilage, this common carotid bifurcates into the external carotid artery, which we will know will go on to supply the face and the more external features of the head via the facial and maxillary arteries. And it also bifurcates into the internal carotid artery, which is going to make its way up into the cranium and supply the brain. As it courses up through the neck, it has to enter the cranium, and it does so through the carotid canal. This canal is formed within the petrous part of the temporal bone and forces the internal carotid artery to make a 90-degree turn as it enters the cranium. The internal carotid artery is responsible for supplying the rostral portions of the brain. The caudal aspect of the brain is supplied by the vertebral arteries. These originate on the subclavian arteries and travel up through the transverse foramina of the cervical vertebrae. We have one coming up each side, just as in the internal carotids, but these enter the cranium via the foramen magnum, before coming together and forming a singular basilar artery. Now we have an idea of how blood vessels enter the cranium, we can focus on the way that they supply the brain, but we need to have a different angle for this. This is the underside, or the ventral side of the brain. We have the olfactory bulbs here and the olfactory tract, so we know that this is the rostral brain. We also have the cerebellum in place, but we have removed one hemisphere of the cerebellum so that we can see where more of the blood vessels travel to. These red vessels are the internal carotid arteries that we saw from a lateral perspective a few moments ago, whilst these down here are the vertebral arteries that form the basilar artery. If we have a look at this skull, for the purposes of orientation, we have the anterior cranial fossa here, with the cribriform plate of the ethmoid bone. So we know that this is where the front of the face is. Here we can see the carotid canals, where the internal carotid arteries make their way up from outside the cranium to inside the cranium. They are located within the petrous part of the temporal bone. We can also see the foramen magnum, which is the huge hole in the occipital bone that allows for passage of the spinal cord out of the cranium, but also allows for vertebral arteries to make their way from the transverse foramina of the cervical vertebrae into the cranium to supply the caudal aspect of the brain. Here we can see where I've sketched on the internal carotid arteries, whilst here is the vertebral arteries that have entered the cranium. And these are those arteries located on the brain itself. These arteries come together to form a junction of arteries called the circle of Willis. The circle of Willis, technically speaking, is only these collection of arteries here. However, very rarely do we see text or literature referring only to these arteries. We always associate the whole system as being the circle of Willis. Therefore, in any further learning objectives you come across during your programme that refer to the circle of Willis, you should probably consider this to mean the whole cerebral circulation, including the caudal aspect of the vertebral and basilar arteries and their branches. This image on the right is going to help you translate those schematic diagrams that you see in the self-directed elements of your study, whilst the brain on the left will help you locate those arteries on cadaveric images. This left image will also help you to understand the areas in which those branches supply, and therefore will help you identify any pathologies you see as a result of vascular injury. And so, the first artery to label is the internal carotid artery. We have spoken about these many times today, but now we can see them in situ. And we know that these form the arterial supply that begin the circle of Willis. A continuation of these arteries are named the middle cerebral arteries, not to be confused with the middle meningeal arteries, which travel up from the maxillary artery of the face and deep to the terion of the skull. These middle cerebral arteries travel up through the lateral sulcus and supply most of the frontal, parietal and temporal lobes of the brain. The internal carotid also gives off two anterior branches, called the anterior cerebral arteries. These travel deep within the sagittal fissure of the telencephalon between the two hemispheres, and supply the most medial 1 centimetre of each hemisphere and the medial surface of the brain, as far back as the caudal parietal lobe. They are joined together by an anterior communicating artery, which is a bit of a weird one, as normally an anastomosis between two arteries gives us a backup plan if one artery fails, but not in this case. Assuming that this left anterior cerebral artery becomes occluded or blocked by a pesky clot, the blood volume travelling through the anterior communicating artery is not sufficient to prevent infarction of the left medial hemisphere. So if the anterior cerebral artery is blocked, the left medial, frontal and parietal lobes will suffer the consequences of ischemia or infarction. In fact, the anterior communicating artery is considered to have almost zero net blood flow, but it's believed to be involved in the blood sodium regulation. But that is way beyond what you need to know for this programme. What we do know about this artery is that it becomes very clinically relevant for the site of aneurysms, something which we will come on to in a short while. Moving on, we have the caudal supply formed by the vertebral arteries, which give rise to the anterior spinal artery. This artery travels down the anterior or ventral aspect of the spinal cord. The vertebral arteries also give rise to the pica, or the posterior inferior cerebellar arteries. Here we can see one of these arteries on the back underside of the cerebellum supplying the cells there. The pica branch off and form the posterior spinal arteries, which is not seen on our schematic diagram, but can be seen on the brain here and here. These are travelling posteriorly or dorsally down the spine. Just after the vertebral arteries join to form the basilar artery, another set of arteries are given off. These are the ACA, or the anterior inferior cerebellar arteries. These supply the front inferior portion of the cerebellum, as we can see here. Just before the basilar terminates, we have a superior cerebellar artery. These travel between the cerebrum and the cerebellum in a space called the transverse fissure and supply the superior surface of the cerebellum. And just as the basilar terminates, it gives off two posterior cerebral arteries. Again, these travel within the transverse fissure, but these arteries are not supplying the cerebellum, but instead are supplying the underside of the cerebrum, including the medial aspects of the occipital lobe. The final branches of our posterior brain supply form the closure of the circle of Willis. These are the posterior communicating arteries, which, in contradiction to the anterior communicating artery, are able to provide a collateral circulation to the brain and spinal cord, should one of the systems become occluded. We also have some little branches here. These are branching from the basilar artery and are the pontine branches, which are supplying the pons of the brainstem. Now you'll notice that all of these branches on the brain are quite small, and we know that the brain requires a lot of blood for its high metabolic demand. That means the pressures within the branches of the circle of Willis experience quite a high volume and pressure of blood, which can lead to problems. Arterial joints are typically weaker than continuous vessels, and as we've seen, there are a lot of joints around the blood vessels of the brain. This can lead to bulging of the vessels in a pathology called an aneurysm. We can get an aneurysm in any artery of the body, a more common one being an abdominal aortic aneurysm. But we expect aneurysms to form in arteries that are in undue stress, such as the massive abdominal aorta or the arteries of the brain. But not all aneurysms are the same. In the aorta, for instance, we typically find a large, smooth bulge within the walls. But within the brain, we find that these arteries pop out like little grapes or berries from the arterial walls, normally near the join of two or more arteries. If these arteries rupture, their large net flow of blood can empty into the cranial cavity, not only increasing the intracranial pressure and compressing the brain, but also starving the brain from any necessary oxygen and glucose that it needs to survive. Quite often they go undetected until they rupture, but in some areas we can develop symptoms that can alert us to their presence. For instance, berry aneurysms near the optic chiasm, such as in the proximal anterior cerebral arteries or the anterior communicating artery, can compress the optic chiasm and cause visual disturbances. Or we may experience headaches from the irritation of tissues around the aneurysms. Approximately 10% of vascular strokes are caused by rupture of one of these berry aneurysms, and the consequences of which can vary from mild impairments to catastrophic brain death, depending on the severity of the bleed and or the skill and timeliness of a surgical repair. So now we've seen the vessels in question, let's have a look at the areas of the brain they supply, and therefore the pathologies we might see should these vessels become blocked or ruptured. The anterior cerebral artery supplies the middle 1 centimetre of each hemisphere, as shown in blue. The middle cerebral arteries supply the lateral frontal, temporal and parietal areas. And when we come on to the next image, we'll see how potentially devastating an occlusion to these arteries could be. And finally, the posterior cerebral arteries supply the occipital lobe and the inferior and medial surface of the temporal lobe. We have the same colours here indicating the supply by each large vessel. And the first one is the middle cerebral artery, within the lateral sulcus of the hemispheres. The middle cerebral artery supplies most of the frontal, temporal and parietal lobes. So damage to this artery, depending on whether it's the artery itself or one of its many branches, could result in numerous deficits for a patient. If the proximal root of the MCA is occluded, we could lose supply to Broca's area, Vernices, the primary somatosensory and the primary motor areas, as well as the frontal eye field. The anterior cerebral artery supplies the medial 1 cm of each hemisphere, as shown in blue. So we could expect the supplementary motor areas and the primary motor areas for the feet and legs may be affected if it is starved of blood, as well as the general somatosensory and primary association for the areas of the feet, genitals and legs. We also know that the medial frontal lobes are responsible for our higher order thinking and impulse control and rationale. So we could expect that damage to the medial frontal parietal regions could affect sensory and motor functions of the lower limbs, but also hugely impact our personalities and impulsive behaviours. The PCA is going to supply the occipital lobe, so we could expect visual deficits or the ability to interpret images if this vessel is occluded. And finally, we could see a coronal perspective of the same arteries and regions of the diencephalon that might also be affected. Included our coordination and voluntary movement and memories. Remember that the thalamus acts like a switchboard, sending messages off to the appropriate cortex or region of the brain. So a posterior cerebral artery fault may have many consequences from a neurological perspective. That has summed up the arterial supply. But before we can look at the drainage, I need to explain to you about the meninges of the brain. The image on the left shows us the top of a cadaveric head, whilst the image on the right shows us the spinal cord. We have several layers of tissue between the skin and the brain, so let's run through them on this image first. The skin is the outermost layer, and the loose connective tissue lies directly beneath this, followed by the musculo-aponeurotic system of the occipitofrontalis muscle called the epicranial aponeurosis. Deep to that we have another layer of areolar tissue that helps prevent the aponeurosis sticking to the skull, which is here, followed by 3 more layers. 1, 2, 3. These 3 layers are the meninges. These are the focus of today. We have the dura mater, the arachnoid matter, and the pia mater. The dura mater, or tough mother, is the outermost layer of the meninges, which can be seen here. It can also be seen on this image here with this window cut out to allow us to see the arachnoid tissue beneath it. The dura mater consists of 2 layers, called the periosteal layer, which attaches to the skull, and the inner layer called the meningeal layer, which lies closest to the other meninges. The space between the periosteal layer and the skull is called the epidural or extradural space. Deep to the meningeal layer of the dura, we have the arachnoid matter. This tissue can be seen covering the bridging veins of the brain and contains granulations that look like spiders' eggs wrapped in webs on its superficial surface. The arachnoid matter sits close to the meningeal layer of the dura, and the space between the dura and the arachnoid is called the subdural space. Beneath the arachnoid, we have a single, thin layer of delicate tissue called the pia mater, or tender mother. This microscopically thin layer is anchored to the brain by cells called astrocytes, and it cannot be peeled off like the other layers of the brain, as it sinks deep within the sulci of the brain, forming an impenetrable barrier that only allows vessels and the ventricles to perforate the layer at given areas. The space between the arachnoid and the pia is called the subarachnoid space, which is where we will find cerebrospinal fluid. This is a very simplified sketch of the layers of the meninges that we have seen. We have the skin, the skull, which are most superficial, and the cerebrum, which is the deepest region. The most superficial of the meninges is the dura mater, which is made up of the periosteal and meningeal dura, and in most cases of the brain, these are so tightly bonded together that they look like a single tough layer, but they do come apart at various points to produce channel-like spaces called sinuses. But more of that in a minute. Beneath the meningeal dura we have the arachnoid matter, with its granulations showing perforations through the meningeal dura. Beneath the arachnoid matter we have the final layer of the meninges, the pia mater, that is anchored tightly to the CNS, in this case the cerebrum, but it is the same on the spinal cord. The space between the arachnoid and the pia mater is the subarachnoid space, whilst the space between the arachnoid and the meningeal layer of the dura is called the subdural space, and the space between the periosteal dura and the skull is termed the epi or extradural space. On this coronal cadaveric image we can see some layers of the dura around the brain, but let's just zoom in on this space to see how the two layers of the dura separate and how this interacts with other layers of the meninges. In pink we can see the dura mater, and we can see that there are two layers. We have the periosteal layer and we have the meningeal layer. The space that they make when they come apart is called a sinus, and this one, because it is superior and follows along the sagittal fissure, is called the superior sagittal sinus. The meningeal layer also reflects and forms a fold which is used to support the brain and isolate different areas. These are called dural folds. Superficially to this pia mater we can see these bridging veins and cerebral arteries. These are sat within the subarachnoid space, which will become relevant in just a second. So you've likely at some point heard of the terms epidural, subdural and subarachnoid bleeds. They are quite often featured on crime or hospital procedural programs. But what do they mean and what causes them? Well, an epidural bleed happens within the epi or extradural space, and it is usually down to that pesky middle meningeal artery becoming injured due to a blow to the side of the head near the pterion. Because it is a bleed outside of the meninges, this leaking vessel peels away the periosteal layer of dura from the skull due to the influx of blood. So when we look at a CT scan, it forms a convex shape between the brain and the skull. A subdural hemorrhage is normally caused by a torn bridging vein that is travelling to the venous sinus. This fills the subdural space with blood. The blood spreads out between the dura and the arachnoid, so we see this characteristic crescent or banana shape around the perimeter of the skull. Lastly, a subarachnoid bleed. This is normally caused by a torn cerebral artery, often as a result of an aneurysm, as discussed at the beginning of the video. The blood escaping travels within the subarachnoid space and mixes with the CSF. Because the pia, forming the deep boundary of this space, is so closely connected to the brain, the blood pooling in this cavity can also invaginate into the sulci of the cerebrum. So we can see how these frilly and poor defined boundaries of a subarachnoid bleed are visualised on a CT scan. We briefly touched on dural folds, so let's now take a closer look at the meningeal layer of the dura mater reflex to produce compartments within the cranium. These folds are designed to protect the delicate brain tissue from bashing about the cranium as we move. The first one is this little one here. This is called the falx cerebri. This sits between the two hemispheres of the cerebellum and prevents them from bashing together. Sitting within the transverse cerebral fissures is the tentorium cerebelli. This prevents the cerebellum and the cerebri from bashing together. And lastly, this large one travelling here down the sagittal fissure is called the falx cerebri, which keeps the left and right hemispheres in situ. The meninges are continuous along the length of the spinal cord and are in the same orientation. The outermost is the dura mater, which lies deep to the epidural space. The epidural space is lined with fat and helps to cushion the spinal cord. Deep to the dura we have the arachnoid that lies close to the dura. Deep to the arachnoid we have the subarachnoid space filled with cerebrospinal fluid. And of course we have the innermost meninge, the pia mater. Extensions of this pia mater are seen here, which help prevent the lateral movement of the spinal cord and are called the denticular ligaments. Some texts may refer to these as the dentate ligaments. Here is a summary slide of what we have covered so far. Pause the video if you wish to move through it, but for now I'm going to continue on with today's learning objectives. So we needed to look at the meninges before this next part will make sense. So let's move forward and look at the venous system of the brain. The venous system of the brain is slightly different to the rest of the veins we've looked at during our journey. The sinuses formed from the periosteal and meningeal dura open up in specific locations to allow for drainage of the brain. These sinuses act like veins, but they are not constructed in the same manner. Veins are constructed from endothelial tissue and contain valves, but the sinuses are constructed of dura and contain no valves. These sinuses drain into each other and eventually down into the internal jugular vein and back to the heart. The one we have already been introduced to runs with the superior aspect of the sagittal fissure, and so this is called the superior sagittal sinus. Running along the free end of the falx cerebri, we have the inferior sagittal sinus. We also have this very special sinus here. This is the cavernous sinus. This acts like a vein, but it is also important to remember that the cavernous sinus contains other substances rather than simply waste metabolites. The cavernous sinus contains the oculomotor nerve, the ophthalmic nerve, the abducens and the trochlear nerves, and it also contains the internal carotid artery. We have the superior and inferior, although the latter cannot be seen here, petrosal sinuses, the sigmoid sinuses, the straight sinus, a confluence of sinuses, two transverse sinuses, and finally the great cerebral vein of Galen. But how do all these join together to provide a venous system? On this flowchart we can see the pathways of venous drainage. The superficial veins drain into the superior sagittal sinus, whilst the deep veins drain into the great vein of Galen. The inferior sagittal sinus drains into the straight sinus with the great vein of Galen. The superior sagittal sinus and the straight sinus drain into the confluence of sinuses, which then drains into the transverse sinuses. Anteriorly, the cavernous sinus drains into the superior petrosal, and to the superior petrosal and the transverse sinuses drain into the sigmoid sinuses. The sigmoid sinuses are the direct link and drain directly into the internal jugular vein, which can be seen here. Now we've covered the blood supply, it is time to look at CSF production and circulation. We have these hollowed out areas of the brain called ventricles, and these ventricles create and circulate cerebrospinal fluid throughout the whole of the CNS. They are a continuous channel in which CSF is produced and passes through into the subarachnoid space. We can see a lateral perspective, an anterior or rostral perspective, and a coronal perspective in which we have cut away a slice of the brain to look inside. This image on the right should look familiar from the introduction of neuroanatomy video, in which we looked at the development of the CNS, and it is also relevant for showing where the ventricles developed. The lateral ventricle developed from the telencephalon. The third ventricle developed from the diencephalon. The cerebral aqueduct is formed from the mesencephalon, whilst the fourth ventricle is formed from the met and myelencephalon, and the central canal continued down into the spinal cord. But how do these ventricles look? What is what? Well, we have two lateral ventricles that sit one in each cerebral hemisphere as a mirror image of each other. They are formed by a body, an antrum, an anterior horn, a posterior horn, and an inferior horn. The third ventricle is singular and sits in the midline of the brain between the two thalami. And the fourth ventricle is also singular and is the space between the pons and the medulla of the brainstem and cerebellum. Connecting the lateral ventricles to the third ventricle are these little tubes called foramen of Monro, or intraventricular foramina. And connecting the third ventricle to the fourth ventricle is a singular duct called the cerebral aqueduct. The fourth ventricle has three openings which allow the CSF to drain into the subarachnoid space. A single aperture in the midline is called the median aperture, or the foramen of Meningeal. Two lateral apertures, called the foramina of Luschka, also allow the CSF to drain into the subarachnoid space. You can remember which way round they are by lateral and Luschka, and median and Meningeal. The third ventricle can be difficult to visualise because we cut away the walls when we cut along the midline. The third ventricle sits between the two thalami and drains into the cerebral aqueduct before entering the fourth ventricle and being dispersed into the subarachnoid space. Here we can see a summary flowchart of the course of the CSF through the ventricular system. And here is the summary slide of the ventricular system. Feel free to pause the video if you want to recap what has just been said. CSF, or cerebrospinal fluid, is produced in the ventricles of the brain by the passing of blood plasma through tiny fenestrated capillaries within the subarachnoid space. An extension of the pia produces a complex called the choroid complex within the ventricles of the brain. These plexuses allow filtered blood plasma to be transformed into CSF and deposited within the ventricles. These choroid plexuses can be seen in the ventricles during dissection and look like tiny cauliflower florets. Once created, the CSF moves through the ventricular system until it reaches the fourth ventricle and passes into the subarachnoid space surrounding the CNS. It does this by passing out into the lateral apertures, or the median aperture. As the CSF moves around the subarachnoid space, it eventually meets the arachnoid granulations, the majority of which are located up by the sagittal sinus. The granulations pierce the meningeal layer of the dura mater and allow CSF to drain into the superior sagittal sinus, which then follows the normal drainage pattern into the confluence of sinuses, the transverse sinus, the sigmoid, and eventually into the internal jugular vein, where it continues to circulate via the heart. If there is a blockage, we can see pathologies like hydrocephalus. Upstream of the CSF circulation accumulates undrained CSF and the ventricles begin to swell. This radiograph demonstrates the extreme swelling of the lateral ventricles. These are filled with CSF fluid. This is commonly known as water on the brain. Modern imaging techniques normally allow for diagnosis in vitro. Soon after the baby is born, assuming there are no neurological deficits, a shunt can be placed into the ventricular system and allow for drainage of CSF into the abdomen in a procedure called ventriculoperitoneal shunt, where it is recycled with peritoneal fluid and eventually excreted out. The CSF is produced by the choroid plexus and is circulated in the subarachnoid space of the central nervous system. It acts to aid buoyancy and cushioning for the delicate structures of the CNS and is used to transport substances and waste material in and out of the CNS, providing a stable environment for this highly demanding system. And that completes the tour of the blood and the CSF circulation within the CNS. We have outlined the blood supply of the brain and described the key branches, and described the distribution of the main arteries and pathological consequences of an occlusion. We've described the arrangement of the meninges in the cranial cavity and the spinal cord, and outlined the venous drainage of the brain. We've also had a look at the ventricles of the brain, including the choroid plexus, and outlined the CSF circulation. We've been able to describe the functions of the CSF and outline the consequences of obstruction within the flow.